and then that, when you put in eligibility criteria, whether you have really adhered to that eligibility criteria, you don't know. Then there'll be a pressure. Oh, recruitment is going on slow, and then you start, there's a lot of gray area. You can always peddle around. So essentially, the way I look at it, a lot of trials, even I have conducted, won't qualify as very good trials. And so this is something that you guys should be aware of. That you and me might feel that, oh, I'm doing really great. Nothing, unless you have big trials with a lot of funding. Like we have now a trial with a lot of funding. We are getting staffs for that. Who is going to recruit? We are putting, how you're going to check whether somebody is doing. Simple. I keep telling my students and staff there. If somebody is entering the data, how sure are you that that data is not having any error or something? It's human to make errors. Somebody is there to cross check. No, it just goes in, and then we just pray that everything is fine. But essentially, you have to have a quality system where there's a double entry. There's a software now where you have a double entry system. Then there's a reason somebody else in the central monitoring will sit and verify your data 1% of the charts. There are ways of doing about it. Just to be sure that your data is valid. Okay, because at the end of the day, as Sir was trying to show you, we're going to change policies. And if it is done on trials which are not trustworthy, we have a problem. So like I come up from a specialty where there's a group which is chasing all the authors and pulling them down for data integrity issues. Okay, because some of these trials have shaped a lot of policy decisions and a lot of farmers have benefited. So they're just chasing down these authors because there's been an issue of fabrication and so on and so forth. So that kind of things exist in research. Now that's one extreme, but let's not go there. So essentially what we are going to do in this session is just trying to see how biases come into a trial. That's all. So I'll try to give some examples. They're mainly for my specialty, but I'm happy to probably take some from yours. So we're just going to go through this risk of bias. The COVID vaccines, when they came in, we all jumped in, isn't it? This was spread during the COVID time. So I think the Oxford trial came, and also, were you 100% sure that this vaccine works? Because finally, I think the trials, when they were done, they came from the Oxford group, so you kind of trusted those, and we went ahead and took those vaccines. But you can always have issues with the manufacturing and so on, or there could be a cut. Once things are published, I think there are a lot of retractions in famous journals for COVID. I'm not a medicine guy, I just keep forgetting, but I know. So people rushed in because there was a time factor, and then they realized that there was a problem with these trials and they retracted. So that's what you're going to do here. So I'm not going to talk very technical. I just want to probably give you the concept behind it. So you know that you're looking at evidence. You want to see whether drug A is working better than drug B and so on. So there are two terms you need to be aware of. One is internal validity and one is external validity. Okay. So internal validity is what we are looking at. Is this trial trustworthy? That's the bottom line. Yeah. External validity is, as Sir was saying, it is about applicability to other settings. So if some trial is done in Japan or US, whether that trial is applicable to us. So that's a separate question. So external validity changes depending upon the setting. Internal validity, if the trial is trustworthy, whether I am assessing it here or somebody is doing in UK, it should not change. So we have two types of error. One is random error, which is by chance, okay, and one is systematic error. So we are worried about the systematic error. So if I give you an example, if you're doing a trial on antihypertensive drugs, and if you have instrument which is faulty, so no matter what your trial results are, end of the day, the quality assurance guy goes and checks out the instrument is faulty. The whole trial essentially has a systematic error. Yeah, it is biased. Now, I'm just giving a hypothetical example, but you can probably correlate, So if you have a weight reduction trial or something, like we are doing one on that, if you have a problem with that or how it is measured. I'll just give an example. It just came to our mind. We had a feasibility study. So we were actually looking at lifestyle intervention and looking at waist circumference and reduction of waist circumference and so on. So I looked at the data what my students had entered, and then we figured out this lady has had a advice at baseline. Waist was 84. Then at 3 months after lifestyle intervention, it became 88, and at 6 months it was 102 or something like that. Okay, so weight reduction was going the opposite. So what would explain this? Or let's say the difference was 10 centimeters within 3 months. What would be the reason? Wild guess. The person who was measuring, okay, the tape over the clothes, there was no real SOP out there. So one lady might have had a pretty different dress and they would have measured the thing, because they are not really motivated. As I said here, the motivated staff is very important. And now people think it like, oh my God, this is an extra work over and above I'm doing. I'm not getting any salary. You'll get results like this one. Yeah. So I had to red flag those findings. So essentially I said, just get me the weight, forget the waist circumference, because and now for a big trial we are making an SOP, how to exactly measure, simple thing, but it has gone horribly wrong, because now the lady has left. You can't go back and check now. You can't go back into time. So this affects the validity. Yeah. So that's where the systematic error will come. Now, the worry is that a poor quality trial will actually muddle up the whole meta-analysis. Yeah. So what will happen is it's going to make everything look big, or you find that the drug actually has 5% benefit. It might go other way around and say 25% benefit and so on. So I'm going to give you an example. You tell me what I'm going to do. Anyway, answers are there. This is what sir was showing. You have a trial. You can see that trial had pretty good results in favor of intervention. And there's one trial which did not show effect. But because you're doing a meta-analysis, 2 trials are required. This is what your results are. Yeah. And risk ratio is 1.3, 30% benefit. Will you go and change practice? One is a poor quality trial, all muddled up, and the other one is a high quality trial. What will you do? Exactly, this is the dilemma. This is how your systematic reviews are going to come out, and you are supposed to understand all this. So this is the dilemma you will face when you start pooling it. So how did I figure out it's a poor quality and high quality trial is what the risk of bias is going to be. But you need this information. If you don't have risk of bias, you just go and pull it out. I'll tell you, I'll show you one more example where we had a problem in kind of finally capturing. See, when you go through a Cochrane review, it's an 80-page document. You and me will not have the time to go through the whole review. You will zoom into the conclusion and abstract. So important is, how do you actually summarize in that one paragraph? And that's what all this whole story is. You will go through all this, you'll read today's ROB, and then you'll go through meta-analysis and grade and stuff. But ultimately, the authors have a challenge to capture that in one paragraph so that people don't go and change practice. They understand what it is. So as I said, you can have problems right from planning stage, wrong design, execution. So do you think we have a problem at the conduct stage? I think we have huge problems. Yeah. So design, you can still get it right. So now just some technical things. So if you are doing a risk of bias, so let's say I'm doing a Cochrane, I will have one more person doing the same thing. So everything has to be duplicated in systematic review. Yeah. And they have software. So right now we are working on a Cochrane. So I'm doing the screening using the Covidence, which is the software where you have all the studies. And my colleague is also doing the screening simultaneously. And both of us screen. And at the end of the day, there'll be conflicts in terms of our decision, and then we resolve them. Yeah. So that's where everything in systematic review has to be duplicated, because again, you can make the same mistake. So this was a search thing, and I think this is what I'm going to show. And you can have problems right from selection bias, performance bias, and I'm going to now just go through each of them. That's what we want to do now. Yeah, this is how. So don't worry. This all looks very colorful. Everything is software. You don't have to really do much. You just have to make your judgments, and I'll tell you how we'll do that. So I'm using our specialty example, but then I'm going to come to what. So there's a couple who is undergoing IVF. The male partner has a problem, and we are giving antioxidants, something very easy. And the other arm, there is no drug being given, and our outcomes are quite objective, binary. I don't know how is it in neonates. In neonatal, almost it's easier to handle binary. Continuous is not easy. If you are in, I think, specialty in psychiatry and a lot of continuous outcomes and all, and pain and so on, that becomes a little difficult. Again, COVID example. So these are your PICO statements. We are looking at alternate medicine. So we're going for a workshop. So they wanted us to look at yoga. So we looked that also. But here you have continuous outcomes. So let's move on to, these are the broad 4 or 5 domains, 6 if I can say. And I'm just going to rush through these 6 domains. So this is what your judgment is going to be on for each of these domains. So how do you look at the selection bias? So I'm not going to go into detail. I'll just show you this. Yeah. Okay. Let's say this slide actually captures what it is. So selection bias is basically randomization and allocation concealment. So what exactly do you mean by this? What's happening when you randomize? Why do you want to randomize in the first place? Essentially, you want to have people with the same baseline variables. They are similar in everything except the intervention. Yeah, but it's easier said than done. You will find that in a smaller trial, the baseline variables might not exactly be equally distributed, and it is not possible. Even in it depends upon what kind of variables you are looking at. Sometimes I really get worried on the baseline table itself, because there are a lot of confounders which are not captured. You and me in a specialty will know they have not captured this, that. They've just said age, BMI, and they might miss out. So remember that randomization doesn't always get it equal. Yeah, and especially in smaller trials. But main idea of at randomization and that whole process of randomization and allocation concealment is to ensure that you have equally distributed or similar population on both arms. Yeah. Performance bias. Anything that you can tell me on this? There are 2 aspects to this. There's actually performance bias, and there's something called outcome assessment. Yeah, I'll come now. What do you think is performance bias? Neonates, let me give an example. So if you have antibiotic for neonatal sepsis versus you're running a trial, and other arm you're giving your standard antibiotic, do you think knowledge of giving that particular baby that intervention versus the one on control has any change on your behavior as a clinician? You will do extra, simply, because it is a human thing. So now if I make it a blinded trial, you don't know who's got what. Even if you have a tendency to do extra, you will do it for both because you don't know. That is exactly performance bias. Yeah. So in performance bias, the rule of the trial is that you are supposed to just give the intervention and nothing extra. But what usually in clinical practice happens is, moment somebody is randomized and you are aware, you will start doing a lot more because you feel, oh, this patient might get into complication and so on and so forth, and a lot of other fears are there. But even your protocol might ask for an extra visit. So like that Primacoon example that sir was giving, probably in the one with 7 days, you might ask for a few more tests or something just to keep, because you will be worried. So at the planning stage itself, you'll add those things, which is beyond the intervention. So this is what is performance bias. A surgeon, like has a problem. Blinding is not easy in surgery. So your specialty is more suited for all this. Like for us as surgeons, we find it difficult because surgeons will have their biases and you can't really blind, can't do sham procedures and so on. So that's where performance biases. I'll come down to outcome assessment bias, which is also together with this. What is attrition bias? I'm going to spend time in this because the examples are easier to carry. I'll be giving examples of each of this. We'll be stretching 15 minutes because I started 15 minutes late and holding off, but I think if it's interactive, we will get there. So what do you think is attrition bias? More people lose out. Yeah. So I'll give you an example what can happen. Let's say you have an oncology trial going on. So maximum number of good trials come from oncology. So you have a wonder drug which is really doing well. Okay. And you have the standard of care. And what happens is the drug is doing really well, but a lot of patients are dropping out of that. Yeah. And when you do something called intention to treat analysis, you will have to account for all those who dropped out and say that they didn't benefit. Yeah. So the final results, what do you think is the reason why they are dropping out? Side effects. They could not tolerate the drug. Yeah. So that is going to lead to some attrition. There can be so many other reasons. So similarly, so if your arms are becoming too much uneven, because of attrition, then you have a problem. So that can lead to attrition bias. So how do you think, at what stage you should sort this out? Attrition bias. Sample size. Plus, you should ensure that your protocol is planned in a way that there's very less attrition. So typically, as I said, we run very so-so trials, but if you go for a big trial, you're supposed to do a feasibility study. Get the patients on board. There is something called public participant initiative. If you don't have that, you can't really launch big trials. Okay, so I'm just telling you the current thing. You get the patients on board, you think about everything, and then only you launch trial. You should not land up in a situation where half of the patients are just dropping off because your whole trial is gone after that. No, if 50% of your patients are not completing the trial, the whole exercise is redundant. Halfway through, you will reach and you'll figure out there's a problem. But that also will lead to attrition bias. Detection bias, where do you think is a classic example? So you'll get that. In psychiatry studies and all, if there is, let's say, no blinding, and you are the clinician, what can happen? The new drug. Patient will start feeling better. You will record it better. So the outcome is being assessed. So patient also might feel that she or he is getting a good new drug and they might start reporting. So things will change. So the way you assess outcomes now, in my specialty and probably your specialty, where there is objective like neonatal discharging, ICO, whatever. I don't want to use the death thing, but like for us, it's live birth. I really can't fudge around with that. So there can't be a detection bias as much. But when you have, these are something that you have to take cognizance of. Reporting bias. What is reporting bias? Tell me this. And I'll move on. Yeah.
Studies with positive outcomes.
Yeah, so I think so I'm also trying to say it's basically you before launching a trial, what do we do? Registry. So what does that registry have? What does that registry have when you're filling in? Outcomes are specified. No? Because you can't change the outcome once you do trial. And why do you think this can happen? And where did this happen very commonly?
The primary outcome changes.
Yeah, what happens? Let's say the pharma guys are interested in a particular outcome and they find that things are not looking good. They will drop off. So for us, like there's live birth, there is clinical pregnancy, there's so many things. And your thing it will be neonatal, let's say sepsis, and then they find one particular outcome only is showing benefit and rest of them not. They might just quietly drop it off. So that's why when you become a Cochrane author, no, you become like an investigator, you know. So I do all this thing quite a bit. You know, moment I look at this author, then I have to go and check what this guy has been up to. You become investigative journalist, or you know, I enjoy that. You know, a lot of funny things happen. So that's where it is. So you can see that a lot of people change halfway through the outcomes and publish it, and that's where your reporting bias will come. Yeah. So now I'm just going to each of the domains. So the first one is selection bias, for which I just mentioned. You kind of are balancing the confounders and minimizing selection bias. So how do you think we can do randomization? I've given you the answers. How many are still doing that one? Computer generated and all. Your generation is ahead of us, man. We are already behind. So there is web randomization now. No? So people are actually, all the good trials are doing web randomization. You know, computer table and all that was in my era. Okay. But what do you think is the problem with that? You can randomize according to your day of OPD, no? Tuesday is unit 1, Tuesday, Wednesday is unit 2, whatever. Patients coming to unit 1 in one thing. Can you do that? Their visit. What do you think is the problem?
Who's getting?
You can always tell him, okay, you go to unit 2. Okay, so you will know. And if you feel this patient is prognostically going to create a problem, you can always change. So that is exactly what I was asking, quasi-randomized trials. Yeah. So the other day, like I was trying to, get in touch with one of the authors, because people use this word randomly very, very liberally in studies. So half of the time I'll be scratching my head and figuring out whether this is a randomized trial in true sense or they have just mentioned randomly. Okay. So then as a protocol, we are supposed to write to the authors. Most of them are incommunicative. Okay. They will not respond because they feel it's audit, which is again a problem, because this is where we have a problem. And then one lady did respond saying that we randomize based on the hospital number. I was very happy because I had to exclude it. Okay. But then she made the error of responding. Okay. Most of the time people don't respond, and then I had to put her under unclear bias, you know. Take it. So the way it is going, I just thought I would tell you. So that is not a truly randomized trial. This is what it is. So there are studies, earlier which clearly showed that non-randomized trials overestimate the treatment effect. What does exactly this jargon mean? Essentially means if it is showing 5% benefit, it will start showing 20%. Yeah. So exaggerating the true effect. Now this, I don't know how clear is this. This is exactly what the RevMem will throw at you when you are trying to do a risk of bias. Okay. So you can see this judgment here. Yeah. Okay. So I am making a judgment unclear. Yeah. Is it visible? I don't know. It's too. Okay. Children were, so you have to support that judgment. Children were randomly allocated to 3 regimens. Exactly what I was talking to. They are just using that word randomly. I don't know what it is. So I have to put unclear because they didn't describe what exactly they did. 10 years back, this all was okay. Nowadays, this is not acceptable. Okay. So my judgment for this is unclear. I have put it a low risk for this article. So this is a drop down. Okay. So it's all very simple, but you have to read that article and come out with exactly. So you actually quote unquote when you do that. So nowadays we are doing that. So that's the risk of bias for randomization. This is where most of the trials get it wrong. So allocation concealment is a very important part. Otherwise, the whole randomization process is compromised. So this is where people get it wrong. So that's why I said web randomization is the future, because it has a hidden allocation concealment. You can't really do anything. Once you log in, whatever is generated is allocated. So you can't change that. So that's why that's what. But in our era, when we were doing, we used to have the sequentially numbered, opaque envelope and so on and so forth. Okay. So they are numbered 1 to 10. The first patient comes, you open that one, A or B, allot that. Okay. Now you can put it back and then take the next one and all. Okay. So people can do a lot of things with this. So that era is gone now, but it still finds it mentioned. So essentially, people should not know what's in there, and once they open, they have to give that. You can't change that. That's what it's trying to say. So allocation concealment is not the same as blinding. That happens once the patient is in allotted that. So just remember that thing. Again, it's the same thing. So it's a very busy slide, but I'm just trying to show you. Allocation, this was just as low risk. Why? No details were specifically provided, but central randomization was done. So it is assumed that it is low risk. So that was the reason for my judgment. This one, allocation concealment, I put high risk. Why? Each main investigator had an open list of randomization provided by the coordinator, and then I had to quote the correspondence from the guy. Yes, the investigator would know beforehand. So basically an open list, and the guy knew exactly who's getting what. So he made the error of responding to the mail. So that went into high risk. Yeah. Now I'm going to performance bias. So I'm going to show you the judgments. As I said, difficult in surgical trials. So I was just giving that example of antioxidant in men. So we had a query from the reviewer that you have allotted one group of men with antioxidant. So why didn't you do a placebo? Because what prevents the men in control group to go over the counter and take that drug? You understand? So it was a high risk study because of performance bias. Okay, so that's why you need to be aware of this, because this is where a lot of studies will get affected. So in neonates, I think there is a lot of scope for blinding. You can't, you have enough, you can't just say that we can't do this. Otherwise it will compromise. Okay, so here I have made a judgment, high risk. What is this? Okay. This is for, I think the judgment was because there was a single embryo transfer for a lady during IVF versus double embryo. So we felt that, suppose like it's a randomized trial where in an IVF you're putting one embryo versus two embryos. Okay, so typically the patient who is receiving one embryo might be at a lower chance of success. So the clinician knew that. The embryologist knows that. So there is a possibility that you do extra for that lady. So unless you create a mechanism where the clinician is not aware of who has got one embryo and who's getting two embryos, you have a risk of performance bias. So this is, I have quoted, it's an open label study, and there is a chance that the clinician is influenced. That's why it is at a high risk of bias. Okay. Now for the same review, I would probably use a different judgment for detection bias. I'll come down to that. Now here I have put a judgment low risk for performance bias because it's a blinding. Detection, I have explained you this. The same trial for performance bias, I have put high risk. But if you can see here, for detection bias, I have made it low risk, even though it is a open label study. Why do you think I have done that? It's a IVF study with live birth as an outcome. It's a clear, you can't refute it. Nobody can. So this is where, your judgment has to come depending upon the domains. Okay, it's not like everybody is at high risk and low risk. Each one you'll have to go by. And you are making judgment keeping your main outcome in mind. Remember that. This is all double blind, so everything is low risk. So I'm moving to attrition bias. We are fine. It's okay. Again, I mentioned this. Unequal dropouts can lead to bias. I have explained this context. One of the things we do obviously is to do intention to treat analysis. And studies have to account for all the dropouts. So it's just about how much of attrition is acceptable. So if you have a long study, let's say more than 2-3 years, then 20% up to 20% attrition is acceptable. For a short study, maximum 10% is the general rule. Yeah. Basically, if you have too much of attrition, it's going to bring down the power of your study. So how do you identify if some trial says accounts, you should have that Prisma table and you should exactly tell how many have been out. So if you have a trial which reports as 100 patients recruited and 100 patients all reported, everybody had intervention and everybody had an outcome. So what is your judgment about attrition bias? Patient randomized 50-50 in each arm, let's say neonates. All the participants completed the trial. You have outcomes for all, 50-50, everybody. What is your judgment on attrition bias? No bias. I'll be deeply suspicious of this trial. Okay. Okay, because you can't have a situation where people will drop off the trial. So this is a cardinal mistake some of the authors do. And then I put a big query out there. This guy needs to be chased, because in real trial you will have attrition. People will have a randomization, then they'll withdraw consent. Neonates, I can bet that will happen. You are starting something, baby is not doing well, parents will withdraw. Anyway, it's the parents who have to do that. So I see that. That's why your trials have to really think 100 times before you launch. You have to involve PPI before you launch it, because otherwise you'll have a lot of attrition. So, but for theoretical sake, I have pushed no missing data and so on, but I know that this is something not adequate. Yeah. Essentially, you try to work around this by doing intention to treat. So I'm just giving an example on this. We have judged this as a high risk for attrition bias, because out of 142, I think in the INH regimen for tuberculosis, there was 53% attrition versus 18%. So there's just too much of mismatch. So we kind of brought it down. We don't trust this. Reporting bias. So this is interesting. I don't know if it will come down. I just want to highlight only, this is FDA, all the trials are submitted, the pharma company submits. So this part is important. According to the published literature for that drug, 94% of the trials are showing benefit. The published literature. So these are the trials which were submitted in FDA for approval. Yeah. So they kind of look at. But actually, those were not published. When they took into account, only 50% of the trials were showing benefit. So what happened to the remaining? They never got published. So usually the authors will not publish negative results. The companies will not push negative results. And this is exactly that you and me should be aware of. Only the successful and so-called, showing benefit trials will come in first. There are a lot of trials which have actually not shown benefit. You and me will never come to know. And that is a big worry. And this is exactly what is reported bias. So as an editor also, our thinking is that initially we will be taking on all the positive studies. At some point we'll say we had enough. Now we will stop publishing positive and then we'll start taking negative. So typically if you see any intervention, you will find a flurry of articles showing benefit. Then slowly it will tail off and you'll start seeing negative. So the editor's mindset also works like that. So be aware that there are a lot of trials which have never made it to you and me. Okay.
For it, how do you move the risk, like negative ones which have not published? How do you search for it?
So ideally, you have to go to the trial registry, and all this should have been registered. So when you are doing Cochrane, you are supposed to search the trials and then ask those authors what happened to the data. If they say it is unpublished, then you have to tell them please share the data. and all that. And lot of, like, we know in our specialty, there was a study which showed, like, in the conference, out of 100 abstracts, only 50 eventually got published. But those other 50 never got published. But that data is also data. So you can do that. So, but this is, you should be aware that everything doesn't come into the surface. So reporting bias is also about clinical registry and all that I have told. But actually, world has moved on beyond this. It's just not enough to, if you have a large trial, you don't only have to register. It's a good practice to go and publish your protocol. Okay, so there are two journals only, BMJ Open and Trials, which publishes this. Okay, both are open access, so please find the fund for it. $3,000 US, but you're supposed to keep that. But I'll tell you the interesting part of it. We are doing that. It's important to do that, because what was Sir trying to mention at the end of the day when he showed that photo? Collaboration. So essentially, the world, I mean, I think some of the groundbreaking trials are coming from oncology and infectious disease, HIV and other things as well. What they are doing is they are saying, okay, we have our protocol like this. We are putting in the public domain. If you guys are interested, you also take the same protocol and start off. Because right now you guys are sitting and trying to learn systematic reviews. But there is the next generation of this, no? What is that? There's IPD meta-analysis. Individualized participant data meta-analysis, where the authors are taking the data from each of these trials and pooling them together. But for that, your PICO has to be very similar. So what we are saying is, I have a trial protocol. You also want to use it, you use it. But all of us should be, and then there are a lot of options. There's something called prospective meta-analysis. So me and let's say you join our forces, we conduct our trial, we will end in 2026. You end up in 2025. You publish your trials, but we collate that data again as a prospective meta-analysis and come in together. I'm just telling you the next generation reviews what we are at. But that's why the protocols are important. They can be published if you have put in your efforts there. Yeah. So this happens very often post hoc, people after finishing off, then they start looking at some subgroup which is benefited and so on. But that should be taken with not hints of sort, loads and truckloads of sort. Yeah, because it's not powered for that answer. Yeah, it's just so I think I will now start up winding this up. Reporting low risk because it was registered. Okay, so see, sometimes people don't report very obvious outcomes. In your neonatal sepsis, if you have something that has to be reported by anybody who's doing a trial and that is not reported, then you should suspect there's some problems. Yeah. Other things are, of course, like premature stopping. Can you stop a trial prematurely? And avoid being put a seal that is biased? How do you do that?
Your interim is showing that just causing more harm.
Yeah, so in your protocol itself, you kind of make that this is something that I will not accept. If it really crosses this way or that way. But just stopping just like that will put it under this. So during COVID, we didn't have a choice. A lot of trials just came to a stop. So that was never factored in. Yeah, but otherwise, as said exactly, in your protocol, you're supposed to set the parameter when you will stop the trial in the interim analysis. Yeah. Of course, there are a lot of other things also, pharma and declaration and stuff. So this is how it will all look. Okay, red, green, and yellow. So now the final question comes. You have a set of trials which are poor quality, and you know how you have found out that because of risk of bias. Then what you can do? You can do a what can we do? You have 10 trials, 8 of them are junk. What can I do? You got 10 trials, 8 of them are bad. I can do stratification, I can do something more. So let's say this is how the RevMam will show you when you feed the data. Can you see here, which is the problematic one in that? The red one, no? What I can do is, there is a tick mark in front of all this, isn't it? I just click a button and take up that trial's contribution. And then see whether the results have changed or not. If the results haven't changed, then I'm not too worried about it. Okay, so this is sensitivity analysis we call it. But it's not like you just decide, oh, this is looking too red and I'm going to do it. You're supposed to have a criteria. How do you identify that? So all this is specified. But I'm just telling you how the software does. So this is a Cochrane we were working on. Now, this is exactly the dilemma you will face. So what is the pool result showing? The wild guess. Pool result is showing benefit for that intervention. This one. Clear? But the best trials are the ones which are totally green here. Can you see that? These two. And where is the confidence interval and point estimate? Exactly sitting at the unit. So when you, the best trial, actually both were published in Lancet, were sitting at unity, where the pool results were showing this. So how will you conclude in this? So in the abstract, what we wrote is, the pool results are showing benefit. So it may benefit. However, when we restricted our findings to high quality studies, there was no benefit. Cochrane review will not give recommendations. It will not tell you, you do this, you do that. It's your judgment. Yeah. So we have put this. It's up to the judgment of the end user to decide what they want to do. So this is how we actually frame. In IVF undergoing women undergoing low quality evidence, we had to make it low quality because there are a lot of poor quality trials. Suggest performing a screening hysteroscopy may increase the live births. However, pooled results from only 2 trials with low risk of bias did not show benefit. This is your conclusion. I didn't say you use this, you don't use it. It's up to your judge. This is how. So final word is, as sir had said, where will this go and feed in? It will feed into the grade, that is summary of findings. So sir was showing this. So you can see here that I have put very low quality evidence. And reason probably is, if you look at here, these are very small font. Very serious risk of bias for most of the studies, downgraded by 2 levels. Moment you downgrade by 2 levels, it already comes down to low. Another level goes down, it goes to very low. And to tell you, actually the wordings are also categorized, in at least in our group. They say if it is very low, no matter what the significance is, you will say we are uncertain. That's it. Okay, I'm not going to go into this, but please be aware that there is ROB2 already. So people have moved on from risk of bias 1 to now what the new Cochrane is coming is risk of bias 2. It has a larger, a longer algorithm. Basically, what was happening was we were getting a lot of trials which were conference abstracts, and we were making decisions like unclear. So it was bringing down the level of evidence. And also this is trying to address that. So this is how the ROB2 works. Just be aware of it. I don't want you to kind of get too much into it. And ultimately, this is where it is. Okay, your experience. That's why I asked you first whether you have done RCTs, because then you will know exactly where things can go wrong, especially in your specialty. And then there is some degree of subjectivity. The other issue is I might feel this is, there is an element of performance bias. Others might not feel so, and so on and so forth. So there can be some. That's why you have to have 2 people with 1 third person as a person who is doing the, what do you say, the empire or something. And that's where it is linked to quality. Pooling of high and low quality studies is what you should be worried about, because that's where it is. Okay, but the final thought I will tell you is that now our group Cochrane, what we are doing is we are doing primary analysis of only high quality trials. What we will present in the abstract is only high quality trial studies. as a sensitivity analysis or as an add-on, we will pool all the trials separately and show in the, somewhere in the manuscript, not in the abstract. So the primary analysis should be restricted to high quality studies is what has been decided by our group, because we got worried that this kind of thing is going on. People are just reading abstract, and moment they say significantly better results, people are moving on. They don't see whether we have written uncertain or poor quality evidence and so on. So our group has decided to move on and just present high quality. If there are no high quality trials, then only we drop down. Yeah, so that's where it is. I think I'll not keep you holding. I'm happy to take any question if you have. But essentially, what it is, it's like you a subject expert is required. I can't sit and judge your trials or your specialty. You have to have that your specialty people sitting. You know the nuances. Any doubts that you have?